to the country, in fact, and he was the one who initiated introducing F&B to the country, and the first batch of F&Bs were trained by him, and now he has all his students going around the country. We look forward to listening to his presentation on reclaiming the last barrier, infection control. Thanks, Ram.
Good morning to everybody, and thank you very much, Dr. Balaji. It's a pleasure to be here, and as you said, I'm quite surprised. On Sunday morning, we have a pretty reasonable turnout to listen to what we have to say about wound management. In the next 15 to 20 minutes or so, I shall try to cover or try to answer some of the practical questions which are raised in the management of infections and wounds. The interaction between microorganisms and wound is quite complex. It can start anywhere from contamination, going to colonization, where probably all you need to do is exercise some vigilance. And then it can lead to a localized infection, a spreading infection, and finally to systemic infection, which may involve intervention. There are several characteristics which have been associated with an increased risk of infections and wounds. This may be in acute wounds. Predisposing factors may be a contaminated surgery, a long operative procedure, trauma with delayed treatment, or necrotic tissue with foreign body and hypoxia. And for chronic wounds, any wound of prolonged duration, a large wound situated anatomically near a site of potential contamination may all be predisposing a patient to developing an infection in that wound. So the first question I'm going to raise is, when do I suspect infection in a wound? How do you differentiate the infection when it is camouflaged in a wound which may be looking essentially non-threatening? The factors which have been raised to be associated with infection would include a probe to bone test which is positive, so the grating sensation when you put a metallic probe and scrape on the bottom of the base of the wound, an ulceration which is present for more than 30 days, any history of recurrent foot ulcers, a trauma, the presence of peripheral vascular disease, previous extremity amputation, a loss of protective sensation, the presence of underlying renal insufficiency, and a history of walking barefoot. All these factors have been associated with the development of infection or the presence of infection in a wound. The next question would be, how do I assess an infected foot ulcer? You need to look at the patient first to see whether there is any systemic signs of inflammation, whether he has a fever, tachycardia, tachypnea, or other findings suggestive of any systemic inflammatory response. You need to focus on the limb to see for evidence of purulence, to see for evidence of inflammation, redness, swelling, pain, and also to assess the associated factors of vascular insufficiency, presence of or absence of neurologic sensations. All have to be looked at to decide whether the wound is likely to be infected. We also look at arterial ischemia, venous insufficiency, and other biomechanical or biomedical problems. It is very important to assess the severity of the wound when you assess for infection. So how do you decide how serious the infection is? This can be categorized into a mild infection, a moderate infection, or a severe infection. When you look at a mild infection, this refers to only a local infection involving the skin and the subcutaneous tissue with an erythema which is very limited around the wound, probably between 0.5 to 2 centimeters around the ulcer, and with no other evidence of systemic inflammatory response. And when I say systemic inflammatory response, I refer to a fever, a heart rate of over 90 beats per minute, tachypnea, and probably either leukopenia or leukocytosis. A moderate infection is that which can be defined as an erythema which is more than 2 centimeters or that which involves deeper structures of the skin and subcutaneous tissue, resulting in the formation of abscess or osteomyelitis, again with no systemic inflammation. And finally, a severe wound is that which is associated with the presence of local infections plus systemic wounds of inflammatory response. Now, what is the reason to decide whether the wound is mild, moderate, or severe? These are classifications based on the Infectious Diseases Society of America guidelines, and a study done showed that if the wound infection was mild, 4% of patients would end up with hospitalization and 3% would end up with amputation. Whereas if the wound was severe, almost 90% required hospitalization and 80% would end up losing their limb. So it is very essential to prognosticate the severity of the infection to decide what the patient would end up with finally. The most important question, how to culture a wound. All of us generally see a wound, take a swab from the wound, and then treat what we get on the culture growth. So there are certain do's and don'ts when you do a culture from a wound swab. The do's would include, for all wounds with suspected infection, it is very essential that you take a specimen from the wound. You need to cleanse and debride the wound before obtaining a culture, because very often wounds can be colonized by bacteria which may not be the cause of infection. You need to obtain a tissue specimen for culture by scraping with a sterile scalpel or a dermal curette or biopsy from the base of a debrided ulcer. So the tissue culture is any day superior to a swab. If there is any secretions or any fluctuation beside the wound, you can aspirate with a sterile needle and a syringe. And it is very important that you promptly send the specimen for culture, gram staining, and ensure that what you send is not contaminated by other organisms. The most important do nots or don'ts would be, never culture an ulcer which you clinically feel is not infected, because the presence of bacteria does not mandate initiation of antibiotic therapy. Never obtain a specimen for culture without first cleansing or debriding the wound, and never obtain a specimen for culture by swabbing the wound or just taking the wound drainage, because it may be misleading. If you look at the microbiology of wounds to decide on treatment, in general, the aerobic gram-positive cocci are the predominant microorganisms that normally colonize and cause infection in an acute ulcer or an acute wound when there are breaks in the skin. So for all short-term ulcers, short-term wounds, you need to cover only gram-positive organisms. Staphylococcus aureus and beta hemolytic streptococci are the most commonly associated pathogens, which means that for all acute wounds, all you need to do is either first-generation cephalosporins or maybe second-generation cephalosporins, coamoxiclav or clindamycin. If the wound is chronic, it may develop a more complex colonizing flora, especially if the person has been exposed to antibiotics. This may include enterococci, enterobacteriaceae, anaerobes, pseudomonas, or other non-fermentative gram-negative rods. So they become polymicrobial the longer the ulcer is present. But always remember what Robert Kocher said. The germ is not important, it is the terrain on which it is found that is important. So swabbing an ulcer and depending on the growth to decide on treatment is probably fallacious. If you look at the specific bugs which are associated with infections, if it is a cellulitis without an open skin wound, it is usually a strep or a staph. If it is an infected ulcer in a person who has not been exposed to antibiotics, again, it remains Staph aureus or beta hemolytic streptococcus, predominantly gram-positive organisms. If it's an infected ulcer that is chronic or has been previously treated with antibiotics, please consider the possibility of gram-negatives. And this is more common in India, where we see patients who present to us usually with a prolonged history of ulcer. An ulcer that is macerated because of soaking, in other words, has been exposed to wetness, can be colonized and infected with Pseudomonas. And for all long duration ulcers who have been exposed to broad spectrum antibiotic therapy, it's a polymicrobial flora which may include gram-positive cocci, Staphylococcus aureus, Coagulase negative Staphylococcus, Enterococci, Enterobacteriaceae, Pseudomonas, and other gram-negative rods, and sometimes also fungi. If it's a fetid foot, extensive necrosis or gangrene, again it is mixed and you need to cover using both broad spectrum gram-positive and gram-negative spectrum antibiotics. So which antibiotic would you select? The first question you ask before you select the antibiotic is there any infection? If you feel that there is no infection, please do not expose the patient to antibiotics. For clinically infected patients, with prior use of antibiotics, which is what the common situation we see in most of our patients, the guidelines from the IDSA say consider anti-MRSA therapy. But I would like to slightly differ, because in India, the predominant flora tend to be gram-negatives. MRSA is generally not a very big problem in our country, so you need to consider mainly gram-negative therapy. I will tell you what drug you choose subsequently for the gram-negatives. If there is risk for Pseudomonas in the form of soakage and wetness, then you need to consider anti-Pseudomonal agent also. And very important, assess the severity to give you a prognosis of what is going to happen. Now, these are the guidelines, the practice guidelines from the IDSA, which came last year, June of last year, on the management of various wounds. This is not limited to diabetic wounds. This is essentially, if it is purulent, the predominant mode of drainage is incision and drainage, followed by culture. Now, these are the antibiotics which are recommended by the IDSA, but as I said, I probably may modify this because most of the West, the problems are with gram-positive Staphylococcus aureus and methicillin-resistant Staphylococcus aureus, which may require vancomycin, daptomycin, or linezolid. In our country, it is more likely to be gram-negative. For non-purulent wounds, depending on whether it is severe, moderate, or mild, usually penicillins or first or second generation cephalosporins are which are required, and probably clindamycin also. If the wound is severe, a very good combination would be piperacillin tazobactam or cefiperazone sulbactam, which we use. Plus, if you suspect MRSA, vancomycin or teicoplanin is indicated. This is a little complicated slide. I'm sorry, it is very small, so people may not see, but I'm just going to run through quickly post-operative wounds in all patients. So if you have an operation and the person develops a fever in the first 48 hours, it is unlikely to represent a wound infection. In such a situation, if the person is systemically well, do not do anything. Observe and send cultures as appropriate. If there is evidence of systemic illness or there is wound drainage with signs of inflammation, you stain the wound discharge. If you find streptococci or clostridia, you treat with penicillin or clindamycin. If there is no wound drainage, then you seek other sources of fever. If the person develops fever more than 4 days after the operation and there is evidence of local wound infection with systemic signs, you need to, if there is evidence of wound infection with systemic signs, begin antibiotics after sending culture from the wound and modify treatment depending on what your gram stain or culture shows. I once again apologize, it's a very busy slide. So what happens? You send a culture, you start empiric antibiotics, and then you get a return of, you get a growth in the culture. How do you look at it? If it is a staphylococcus, the only question you need to ask is it methicillin sensitive staphylococcus or a methicillin resistant staphylococcus? To know that, you need to see whether it is sensitive to oxacillin, methicillin, or cloxacillin. If it is sensitive to any of these, it is methicillin sensitive, for which the drug of choice would be a first generation cephalosporin like cefazolin. If it is resistant to oxacillin, then you need MRSA cover with vancomycin, daptomycin, or linezolid or teicoplanin. For enterococcus, the only question you need to ask is it penicillin sensitive or penicillin resistant? If it is penicillin sensitive, ampicillin, amoxicillin, or co-amoxiclav would be the drugs of choice. If it is penicillin resistant, you need to treat it like an MRSA, vancomycin, teicoplanin, linezolid, or daptomycin. If it is a gram-negative bacteria in India, the only question you need to answer is it an ESBL producer? You identify an extended spectrum beta lactamase producing organism by looking at whether it is sensitive to third generation cephalosporins. If it is resistant to any of the third generation cephalosporin like cefotaxime, cefoperazone, ceftazidime, or ceftriaxone, that means it is an ESBL producer, and you need to use either beta-lactam, beta-lactamase inhibiting agents or carbapenems. The others will not work. If it is Pseudomonas, again, the drug of choice would be ceftazidime if it is resistant, or ceftazidime or piperacillin tazobactam or carbapenems if it is resistant, which we find quite often. Colistin would be the only option in India. If you grow fungi, which is usually Candida, if it is from an ulcer swab, we can very safely ignore it. But if it is from a tissue culture or suggesting evidence of osteomyelitis, ideally you need to know the species to determine whether it could be azole resistant or whether it is azole sensitive. Candida albicans, Candida tropicalis are azole sensitive, for which you need to use fluconazole. If it is azole resistant, you need to use amphotericin B or echinocandins. Please remember the holes in the spectrum. When you use clindamycin, you need to understand it covers only gram-positive and anaerobic organisms. It has no gram-negative cover. When you use vancomycin, teicoplanin, linezolid, or daptomycin, which are all indicated for use against MRSA or enterococci, which are resistant to penicillin, they do not have any gram-negative cover. Cephalosporins are inherently resistant to all enterococci. So if you have an enterococcus growing, none of the cephalosporins will work. Carbapenems have the widest spectrum of activity, which covers everything except probably MRSA. And similarly, quinolones have a spectrum of activity similar to carbapenems. The only sad part is in India, the high level of resistance to quinolones makes them almost universally useless in management of all infections in this day and age. So for gram-positive, as I said, strep, methicillin-sensitive staph, first generation cephalosporin, second generation cephalosporin, clindamycin, or coamoxiclav. For enterococcus, again, the same would work, unless it's, except cephalosporins. For gram-negative, BLBLIs or carbapenems. For multi-drug resistant organisms, we have to now resort to colistin or tigecycline because of the high level of resistance. For fungus, especially candida, you need to look at fluconazole, which is still very useful. Please remember there is no role for quinolones as an empiric therapy in our cases because the level of resistance is upwards of 70 to 80%. And please do not use any prophylactic antibiotics while managing wounds. Lastly, the duration of therapy. The duration of therapy, if it is soft tissue infection and a mild infection, would be 1 to 2 weeks. Moderate or severe infections may require 2 to 4 weeks of antibiotics. If it is bone or joint involvement is there, you need to give a minimum of, if you have amputated the limb, 2 to 5 days of treatment is enough. Residual infection, 2 to 4 weeks, and residual infection, or if surgery is not done, anywhere from 6 to 12 weeks of antibiotic may be necessary in managing osteomyelitis. And lastly, suspect osteomyelitis when an ulcer is chronic or overlies the bone. If it does not heal over 6 weeks, if there is a sausage toe present, a swollen foot with a history of foot ulceration, an ulcer which is accompanied by unexplained high ESR or CRP, if the bone is visible, an ulcer which is deep or extensive or has an area of more than 2 square centimeters. So this implies that you probably need to have surgical intervention with or without a prolonged course of antibiotics. Lastly, evidence does not make decisions, people do. Unfortunately, most of the evidence we have are from studies in the West, whether it is the IDSA or the European Society, which cater to the local surveillance patterns and local susceptibilities, which may not be applicable to India. Our problems are more of gram-negatives, our resistance rates are very high, so you need to tailor that when you decide to apply the Western evidence to our patients. So unless we come up or evolve our local guidelines, I think the guidelines in the West may be misleading. So practice points. Patients with ulceration need to be educated on the dangers of infection because it may lead to loss of limb. Signs and symptoms of foot infections may be diminished, especially in diabetics who may have vascular or neurological insufficiency. Appropriate microbiological investigations are essential before you treat. Severe infections need urgent assessment and intravenous antibiotics. Vascular assessment is also needed. And without urgent treatment, please remember that infection will often progress to necrosis and loss of limb. Thank you.
Thank you, Ram. You nicely managed to juggle between the clinical and the pharmacological aspect of the disease. Are you open for questions now? We know? Yeah, we're going to take questions. Anybody from the floor? Rajesh, yeah.
Again, for patients with an osteomyelitis, diabetic foot osteomyelitis, I think number of studies are coming looking at conservative treatment of osteomyelitis. When do you recommend a conservative treatment of diabetic foot osteomyelitis?
I think if the infection is very localized, probably involving a distal part of the limb, where even if the time to progress, it gives you time to monitor the wound and decide on how it develops, I think you can go for conservative treatment.
Sir, could you please elaborate on that point, no prophylactic treatment on wounds?
Yeah, there is no role for, the role for prophylactic antibiotics in current day medicine is very, 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 very restricted. Probably it is involved for major clean surgeries or where you are going to put prosthesis during surgery. Infective endocarditis prophylaxis, rheumatic fever prophylaxis, post-exposure prophylaxis. Other than this, there is no role for antibiotic prophylaxis in most situations. So if you have to decide whether it is infected or not. If it is infected, you treat. But routine giving antibiotics to prevent infection probably has no role.
Pseudomonas, normally they say you need to hit it with 2 antibiotics. Is that still hold true?
Yes, we don't have randomized double-blind control studies, but conventional wisdom still tells us that because Pseudomonas is one of those highly virulent organisms which evolves resistance during treatment, At least to start with, you need to use 2 drugs, and after 4 to 5 days, you can stop off one drug and continue the other drug alone, assuming it is sensitive.
When I normally get a lot of multi-drug resistant organisms post-debridement on deep tissue cultures, my ID comes and sees the wound and says, when I have the option of only tigecycline and colistin, and the patient has a lot of systemic comorbidities, my ID comes and says, just put local neosporin, it'll work. Don't give colistin. Any takes on that? Because,
If the local wound is what is responsible for the systemic inflammation or other features, irrespective of the comorbidities, you need to treat it aggressively. But if it is a very localized infection, which is again you feel is significant, the next bet would be to remove the focus of infection, because the resistant patterns which we find now is very, very scary. And if we feel that that infection is progressing, we need to be aggressive. So we use combination therapy. But if it's a localized grumbling wound, the best would be to get rid of the focus. Source control is probably the best way to get rid of drug resistance organisms.
So I'm getting a culture report. It says it is sensitive to one of the family. If say for quinolones, it is sensitive to ciprofloxacin. At the same time, it is resistant to levofloxacin. Something like I'm getting culture reports. How to take that?
Yes, it's a very, very practical question. We often find there is a interfamily variation in the susceptibility pattern, but the practical advice would be, if it is resistant to one member in the family, avoid that. Because though theoretically it is possible that one may work, as a simple advice, I would say avoid that family.
Thank you.
A wonderful presentation, one of the best concise and practical infectious disease presentations I've seen in a long time. Your point about culturing and using tissue rather than swab is 100% accurate. How do you instruct the lab to process that? Because we struggle with that. We take a culture, we take a curette sample of tissue, but the lab has us place it into the same swab tube, and then they process it the same way as they would anything else. Do you instruct your lab to process the tissue culture differently than a swab, or is it really the same?
No, actually we don't give them any specific instructions, though they also would prefer, when you send a swab, they are not very happy when you just send a swab with a little soakage of this thing. They would like to get the purulent material entirely. So I must confess that no, I think I would expect them to take the tissue and coat it on the culture plates. But I specifically don't instruct them otherwise. Maybe I should go back and check on that.
Just one question from me. Like in our scenario, I'm talking about Indian scenario. If you are seeing a patient with a severe foot sepsis, what would be a first drug of choice? Do you go with the empirically very high-end antibiotic straight away, or a medium end, or just go step by step until you get a culture report?
If it is a limb-threatening infection, or if the patient has severe presence of systemic inflammatory response, he has other signs of sepsis or features with systemic involvement, or there are significant comorbidities where he may not be able to mount a response, my usual choices, I either go for a carbapenem or a BL-BLI with gram-negative cover. If I suspect MRSA, so one combination which you agree we use in Apollo commonly is we use cephalosporin sulbactam or piperacillin tazobactam with clindamycin. Clindamycin both for anaerobic cover. Even though the BL-BLIs have an anaerobic cover, there is an MRSA activity for clinda, so that will be less, shall I say, stronger than vancomycin. We go for that combination. Otherwise, carbapenems is what I would advise in our population.
To Dr. John, I think we should not instruct the microbiologist. The microbiologist should instruct that we are not going to accept any swab. Like in JIPMA, there is a circular. If you write a word swab, they are not going to process it. Because what will happen, it means you are again doing the same thing repeatedly. So invariably, you will not send a swab. So I think this also has to be in the curriculum, that no swab. What is the point? Wasting the time, and no interpretation has to be done.
Unfortunately, the microbiology departments in most hospitals are still, are not strong enough to refuse samples. They have to accept whatever. In our this thing, we have made it no catheter tips, no Foley tips. All that is, the microbiology will not accept.
Maybe because in a government setup, we have 2,000 specimen, and to reduce the load of unnecessary wastage, it's better to accept what is required. In a small setup, probably earning, okay, you can send it and they'll do it lovely because they have to earn. But actually it's not required, one thing. Second thing, we have a scenario where clinically you are suspecting there is a osteomyelitis. We do X-ray, 65% only sensitivity and specificity. We do bone scan, 92%, MRI 98%, we know. We have all the three facilities available, but you know, in a government setup, lot of pressure, waiting list. What do you advise? X-ray is not showing, but you have very high suspicion, but CT scan, the bone scan and the MRI is going to take time. Should we wait or should we start?
No, I would start antibiotics, but the duration of antibiotics or the question of source control, I would leave it depending on how the person evolves. For example, recently I had a patient who was seen by a podiatrist. He had a surgery, she had a surgery done on the little toe for a suspected osteomyelitis. The removed specimen culture did not show any growth, and then the bone showed evidence of subacute inflammation, but the amputation was done. But the wound refused to heal. In spite of 2 or 3 weeks of antibiotics, it refused to heal, you know, and clinically it was not looking good. So the lady was subject to a second surgery, and that came back as squamous cell carcinoma. So when it doesn't fit in with the flow of events, I think you need to reevaluate and see if there is something we are missing.
In case of severe uncontrolled infections, sir, when do you take a decision for amputation? How long do you wait, or other words?
Now, I think this would be a surgical decision. Since if the limb is, the wound is progressing to enough to, you know, affect the limb or the viability of the limb, the sooner the better. In other words, we always tend to try to salvage the limb, but I think in some situation you have to take the call that it is probably worth sacrificing the limb to save the patient. I can't give you a very specific answer. Sorry.
I can probably, may I answer for you? Because although the question was to him, what is amputation? Amputation is a removal of dead body. What do you mean by dead? It is no blood supply and it is totally disconnected. Dead body should be thrown. So we do amputation. Infection is not an amputation. Infection is an infection. You must try hard by debriding, by opening the bone, draining it, irrigating it. Do something to control the infection, but don't do amputation. That is what Dr. Bal is telling. Save the limb. So any severe infection is there whatsoever, that should not become the criteria for removing somebody's body part. Think it's my limb, think my finger. Will I give it? No. It may become shortened, it may become deformed, but to me there is a finger. So I think infection should not guide you to just straightway go for an amputation.
But I think the question is not that. When do you actually make a clinical decision when you remove the amputation? Well, I would say life takes the precedence over the limb. When you think you're not able to control the sepsis by debriding, with antibiotics, well, you have to take a quick decision. Otherwise, you're going to lose the patient. Septicemia. Yeah.
The life is important. Don't compromise with the life. If patient live, probably 100 reconstructions can be done. If you think patient going to septicemia in spite of your all precaution, save the patient, not the wound or the limb. That is beyond doubt.
I think, thanks very much, Ram. It's an excellent interaction.
Sorry to disturb you. I had a question, sir, because the patient who's has been taken to surgery in OR for this, any wound debridement or any other proceeding, are already the positive patient. How we have to take care of the environment? We have a lot of confusion with fogging and then cleaning, deep cleaning. So we have many confusions. So
this is with regard to what kind of an infection you're talking about?
So it is about MDROs or any other MRSA.
Okay, so you have an MRSA or a pan-drug resistant or a extremely drug resistant organism. Fogging is not advised. We advise what is called terminal cleaning, which means the patient and the immediate vicinity of that room has to be thoroughly wiped down with the approved disinfectant and then ventilated for at least a few hours before the next patient is taken on. So this is referred to as terminal cleaning.
Okay, what about the air duct and then?
No, that is not, because this is these wounds are spread through, these infections are spread through contact, you know, so you need not worry about the air handling systems or
Is there
otherwise.
any other contact timing, like 1 hour, like that, how much time duration?
No, there is no recommendation. As long as it is thoroughly wiped down with the disinfectant and left to dry, which could be anywhere from 2 hours to 24 hours, it's perfectly fine. So before the next patient is taken, at least I would look at a few hours before the next patient is taken, so the cleaning is thorough.
In the particular OT, if you are taken as the first case, or if it is not an emergency, we can slot as last case, or how we have to go?
In our hospital, the policy is anybody who's colonized or infected with the multi-drug resistant organisms, which could be a carbapenemase, carbapenem resistant or an MRSA, they are taken at the end of the list, and then it is cleaned down. If by whatever chance you have to take them in the middle, we take a more protracted time to clean in between the next patient before the next patient is taken on.
Thank you, sir.
I'm sorry, I didn't elaborate on the infection control aspects. I thought this would be more relevant than the infection control aspects.
Thank you very much, Dr. Subramanian.